Farb. Next, we're going to have Dr. Callen come back and discuss about everything related to CT myelography, including static CTM, dynamic CTM, and photon counting CT myelograms. So Dr. Callen again.
I'm back. Thanks, Dr. Farb. That was incredible. I love that experiment at the end. That was very, very interesting. Again, here are my disclosures. I'm going to, again, talk about everything with regards to CT today in 20 minutes. We're going to just talk about foundations, technique, some case examples and troubleshooting, as well as what I think is an important part of myelography is reporting. We're going to move from ventral tears to lateral tears to CSF venous fistulas and sort of the structure that you've seen already. And, just so we're getting our vocabulary correct, we're talking about something here called dynamic CT myelography, which is different than a conventional CT myelogram, which is also different from a digital subtraction myelogram, sort of a word soup of myelography. But, we've just got this beautiful talk on digital subtraction myelography and examples of its excellent temporal resolution. And when we compare that to the pitfalls or downsides of conventional CT myelography, they're sort of self-evident, right? We're taking one static image with a conventional CT myelogram. After injection of contrast, we have essentially no temporal resolution. We have pretty good spatial resolution, but those are things that digital subtraction myelography just wins at, right? The spatial resolution, the exquisite spatial resolution and temporal resolution. But there are downsides to DSM as well. We have a limited field of view depending on where we position our II. Superimposition artifacts, as was nicely illustrated, particularly at the cervicothoracic junction. Often if you want to do breath holding, you will have anesthesia support. You may only be able to look at one side per day if you're doing DSM. But if you combine the strengths of these two exams into one, and you inject on the CT table and scan immediately and perhaps get multiple phases, then you get pretty good temporal resolution with CT. If you use very small slices, sub-millimeter slices or even 0.2 millimeter slices on a photon counting CT, you will get excellent spatial resolution. And then you get these benefits of CT, which are this entire field of view of the spine. You can look at the surrounding anatomy, any sort of bony contribution, for example. You can look at both sides in one day, and if you're treating them, you can treat them in the same setting right there on the table. So we do everything, almost everything under CT. There's been only a couple studies that have really compared the two. This was one of the better ones, I think, out of Germany, where they saw a slightly better detection rate with CT, but there's compared to DSM. But there's always, limitations in these studies in terms of their true assessment. I'm going to touch on photon counting CT a little bit here and show an example later of where it can be useful. Without getting into all the physics of it, I like to think of photon counting CT compared to regular CT, whereas regular CT, I saw that it rained outside because it's wet on the ground, right? I see a big puddle on the ground, whereas photon counting CT, I'm literally counting every single raindrop, right? So I don't just see this puddle, I know how many raindrops there were. And just in basic terms, the detector physics are totally different, right? So the semiconductor pixels are logging each individual photon and its energy individually. And so we get less noise, less sort of interpolation in that way, and very, very thin voxels. And intrinsic in that, because we're counting every photon's energy, we are getting multispectral data, which is going to increase our contrast, essentially, giving us monoenergetic views if we want iodine-only views, bone-only views, and decreasing our artifact. And then there's this very good clinical payoff, which is that we get this high contrast to noise ratio at an equal or perhaps lower radiation dose, which we're particularly sensitive to in CT. That is one of the downsides compared to DSM, is it's more radiation. And that is my presenter view. All right. And here's an example. So here's an example of a patient, same patient we did on the photon counter on the right, on the regular CT on the left. I'm not showing a CSF leak here, but I just thought it was very nice to sort of outline that nerve root sleeve and the sort of contour there. You can see the exquisite anatomic detail that you get on that photon counter compared to a regular energy integrating detector CT. I cannot advance. There we go. But there's a problem, right? Which is that on a CT scanner, we can't tilt the patient. So under DSM or fluoro, we can. We inject, we tilt the patient on the table, we can control our contrast bolus nicely, but we don't have that advantage on CT. If you're going to do this, you have to figure out a way to position the patient and angle their spine. Some people use a folded hover mat, like we did this for a long time, inflate it. It's a patient transfer device to elevate their hips. Or you can use a foam wedge. to elevate them. There's problems with this, though. It's not a one-size-fits-all solution, depending on the size of the patient, how tall they are, and you may find yourself grabbing pillows out of your closet to stuff things on there. Sometimes you're getting things that are very odd to put on your table, and when a patient travels from a long way to see you, it's quite embarrassing to be like using tools out of your supply closet to lift their hips. So because of this, we designed a tilt table for the CT scanner. This is not a very complex device. It's just a sort of a very strong plastic frame that is a hand-operating winch, can basically pull these two sides together and give you the ability to tilt the patient. This hooks directly onto the table, and we found this to be very useful for myelography and allowing us to have that control of our contrast bolus in that way. So just in terms of our experience, the majority of leaks we find are CSF venous fistulas, followed by ventral dural tears, and then lateral tears. So I'm going to talk about CT myelography for each of those now. And again, as has been alluded to already, the first distinguishing factor is that a dural tear is going to have epidural fluid most of the time. A CSF venous fistula will not. And so the first thing we do before we even do anything with putting a needle in the patient is deciding what kind of leak are we looking for. And it's not just the presence or absence of fluid, but we can actually look at some other key features on the MRI to help distinguish what type of leak we want to look for. If we see fluid that is predominantly ventral in the ventral epidural space, there's a good chance that that is going to be a ventral dural tear, and I'll show you a specific way that fluid can look that will give you an even better hint. If the fluid is predominantly dorsal or dorsolateral, it might be a lateral tear, but what's also very, very helpful is look on that top screen right of that image. We see this large outpouching along the side of the spine. This is this herniated arachnoid pouch that we frequently see with a lateral dural tear. The presence of this very much indicates or suggests that we're dealing with a lateral dural tear, and frankly, in some cases, you might not even need to do myelography other than to just sort of show the anatomy a little bit better for your surgeon, but that's probably where the leak is. It's very important, I'll talk about this in my patching talk, to understand this concept that these ventral epidural fluid collections, or epidural fluid collections from ventral tears will change over time. This is the same patient at presentation. Look how the fluid is just egressing out of the neural foramina. It's layering dependently in the epidural space, but then they received a non-targeted patch, and then months later, their fluid collection looks totally different. It's confined to the ventral epidural space with these well-demarcated convex outward margins. It's very, very different. So when you see a collection that looks like that, you're thinking this is probably a ventral tear and it's probably a little bit more chronic. So when we're suspecting a ventral tear, we're going to position the patient prone to have that contrast layering along the ventral aspect of the thecal sac. We're going to lower that CT table as much as we can so that we can elevate their hips as much as we can. And it's not just elevating the hips that we want, but we really want to evaluate our scout image before we start injection. This patient on screen left has a very exaggerated lumbar lordosis. It's creating almost a hammock effect. It's going to trap that contrast, and we're going to have to go in and reposition the patient so that we can get the contrast to move down. We're going to lose our temporal resolution. So we don't want that. What we're trying to do is achieve a nice downslope all the way down the spine so that we don't have to go in and move things around after we've done an injection. Also, we're thinking about radiation. We can plan our scan range to minimize this. We don't need to scan the whole spine. Some SLECs cover the entire spine, but not all do. Look at this one. It's very, very small. And we can just limit our scan field of view to the area where the SLEC is. That can help a lot. Also, there was this very nice sign described by Dr. Carlton Jones in the UK recently, the so-called flow void sign. Sometimes you will see that little flow void from the jet of contrast at the leak site itself and kind of give you a hint. And particularly if you're dealing with a larger patient or a patient that's not great quality, like this leak here is a very, very tiny and subtle, but using that MRI to sort of corroborate and say, yes, that is giving me more confidence that that's what the leak is, or perhaps a good way to sort of focus your exam. So this flow void sign. I also like to get a non-contrast CT, or if you're using photon counting CT, a virtual non-contrast image. It can help you find your little osteophyte or bone spur or spicule, calcified Hoffman's ligament, what have you, and also troubleshoot epidural densities. Like for example, in these images here, we see these sort of little densities out there. Is that calcification? Is that contrast? I'm not sure. It's nice to have your non-contrast image up too, to just say, no, those are little calcifications, not any extravasating contrast. The timing is perhaps most important for a ventral tear more than any other leak in my opinion. Here's an example of a patient on their immediate scan after injection. We see this beautiful extravasation of contrast right there, but on a 30-second delay, there's diffusion of contrast throughout the epidural space, which is a less precise point to tell our surgeon where they need to operate, right? And here's another example. So here's the immediate phase on a patient with a ventral tear. We see that beautiful split of contrast in the lower thoracic spine. On the first delay, we see that still, but then the blue arrows are showing that contrast is starting to pool in the ventral epidural space, kind of starting to look like a regular myelogram. And by our third delay here, we see that this is basically just looking like a regular myelogram, and I would have no idea based on that image alone where the leak is. So very important to get our timing down for these ventral tears. And this is not an exam that you are just going to do, inject, and then walk out of the room and go get some coffee and read your images that afternoon. You're going to be in there the entire time with the patient and reviewing these images in real time. Sometimes it's very straightforward, like in this patient here. We see the split of contrast, we got the leak, great, it's a success. Other times, it's unclear, like in this patient here. They have an epidural fluid collection, but I'm not seeing any extravasation of contrast on this image. What's the deal? What am I missing here? But if I look carefully, look at my contrast bolus. It's a little bit eccentric off to the side. I like to think about the canal in the axial image as sort of a clock face, and I've coded kind of 6 to 8 o'clock, right, on this exam. But I haven't coded the sort of 4 to 6 o'clock portion. And so I just, looking at the images real time on the table, I say, okay, I'm going to inject a little more dye here. I'm going to get coding along that 4 to 6 o'clock portion, and there indeed is their leak. And it was just a little eccentric off to the side. And so you need to be monitoring these in real time so that you can troubleshoot and find that leak for the patient. Here's an example of a challenging case that involved that sort of not perfectly midline leak. This patient has a large ventral and dorsal epidural fluid collection, and we did prone myelography and did not see a leak. We turned them on their side and saw this hazy sort of extravasation of contrast out there on the left, but it wasn't this classic lateral dural tear appearance either. And so what we did instead is just had the patient a little bit anterior oblique, just turn them a little bit with that clock face analogy, getting the dependent contrast bolus, again, in that sort of more axilla region or ventral lateral region, and redid our exam and very much more clearly here see that extravasation of contrast there too. So it's not always just perfectly midline or perfectly lateral. Sometimes you're gonna have to troubleshoot by turning your patient a little bit. Once I find a leak, I just drop a fiducial marker right there on the spine. I love these gold anchor fiducial markers. They were actually made for breast. I don't anchor them in bone. We've never had a problem with them migrating at all. It takes maybe 45 seconds to do. We put it right along the lamina there posteriorly, and it helps our surgeons just know exactly where the leak is, decrease the chance of counting error, decrease time under anesthesia. What my surgeon wants to know when I report these exams is, number one, what is the anatomy of this patient? What am I calling L5? You know, what are we dealing with here so we're all speaking the same language? Of course, what level is the leak? What is my degree of confidence? If I'm not totally sure that this is where it is, you just need to say it. I think this is a leak here, but I'm seeing contrast here. Maybe we should repeat the myelogram. Is it midline? Is it off midline? If they're performing a hemilaminectomy, they may want to know this so they know which side they're coming from to approach. Is there a little culprit osteophyte or spicule there? And then where's your fiducial, right? Even if you didn't put it at the right level, make sure that you get a post image to know what level you are at. If we're looking for a lateral tear, we're going to put them in the lateral decubitus position. And knowing which side to look for, again, is very useful to look for this herniated arachnoid pouch. This is a very dramatic example of one. We can see on our T2 image this large herniated arachnoid through the dural tear here. And this is very, very useful for knowing which side we're going to put them on, because if we don't see this, it can be a little bit tough. These leaks can be very fast. So on this patient here, right after injection, there's traveling of contrast up the lateral epidural gutter, or they can be quite slow. So this patient here, after sequential 2-minute delays, we see that accumulation of contrast in the epidural space, but it's not rapidly leaking like in that other example. So for me, I like to get an immediate scan on these, look at it in real time, and then prep for a 1 to 2 minute delay, because these can be a little bit slower. Here's an example of a patient who I wasn't sure if he had a ventral or lateral tear. We had ventral and dorsal fluid here. And what I did on this patient was I put them prone and I just injected at a higher volume because I was really trying to coat sort of from 3 to 9 o'clock, get that nerve root axilla region. And you can see even on a prone exam here that I see that extravasation of contrast laterally. And we confirm this when we turn him on his side. It was a very nice way to sort of avoid 2 different exams for this patient. So whenever I'm sort of hedging between those two, this is the strategy I like to employ. Just quickly touching on sacral dural tears, it's important to localize these because the surgery can be very challenging, and so knowing where the leak is so we can patch them in the best way possible, having them in the sort of reverse lateral decubitus position for these, and looking for that egress of contrast in the sacrum can be very, very helpful, and again, using the same principles we've talked about so far. Now, to get to everyone's favorite leak type, we're going to talk about CSF venous fistulas, and it's important when we're thinking about these fistulas to know where we're looking for. You know, I think in the literature, we often see this hyperdense paraspinal vein, and sometimes these can just look like that, but sometimes they can arise from the proximal nerve root, they can arise from the distal nerve root and give us that sort of more classic appearance, or they can arise directly off the dura and drain into the internal epidural venous plexus or into the basivertebral vein as shown here. And so your search pattern radiologically has to be involving all of these regions when you're scrutinizing these images. They can also drain to adjacent levels. So just because I'm seeing a hyperdense paraspinal vein here at T6-7 does not mean the fistula is coming from T6-7. We can see that in this patient, the fistula was arising from the level below at T7-8. On our early phase imaging, we see the nidus of that fistula at T7-8, and then it's climbing up that paraspinal segmental vein up to the next level above. So we have to track that origin back, because if we're going to be directing treatment, we need to know what sort of nerve root complex this is coming from. Now, we talked about this beautifully in the talk preceding mine by Dr. Farr, but our number one priority is that we want as dense as contrast as possible. That is going to help us find these fistulas the most, but there are other strategies that we have to employ and think about. So how do we get this contrast as dense as possible? We're going to use super dense contrast. IsoView M300 is what we use, and there's this conventional thinking that we can only use 10 cc's of this. We need 3 grams of iodine total. A nice paper came out by Dr. Edelmuth and colleagues showing that it's safer to use higher volumes. I'll use up to 20 cc's sometimes, and it's not a problem for me at all. We don't want to lose that contrast in the head. The patient will not like you. They'll be miserable. They'll have a horrible headache, and their exam will be terrible. So you want to raise that patient's head up to create this sort of hammock effect in the spine to keep that contrast in the spine. You also want to control the bolus, or the puddle. I'm going to steal that. I like that. So what I like to do for this is I will start with a very conservative angulation with our device. I will inject the contrast, less than I think I need. And then there's my contrast column, and if I need to move it up, I'll just angle them up a little bit more and sort of move that contrast, right? I don't want to overshoot it, because I'm never getting that contrast back out of the skull. And if you want to study the other side on the same day, you can do this different ways. One way is that you can just inject them twice, right? But we're worried about post-dural puncture headache in our patients too. We don't want to expose them to 2 sticks necessarily. You can also just roll the patient over with the needle in place. That was described by Dr. Carlton Jones very nicely in this article. How I like to do it is I will puncture them. I'll inject my contrast. After I elevate their hips and measure their pressure, I'll inject my contrast and do a run on this side. Once I'm done, I will lower the table with the needle in place, and then I will inject additional contrast into the lumbar cistern. And then I will remove my needle and turn the patient over. With that fresh contrast in the lumbar cistern, I can then re-raise them and get a study on the other side of the spine, and it works very, very well. In fact, I find that the contralateral side on these ends up looking better than my first side down. I want to touch on these 3 sort of adjunctive maneuvers because I think everyone likes to talk about them, and I think that it's very important to do so in the context of a fistula. Let's talk about pressurization. So I want to show you this patient who had, we looked for a fistula in, we did no pressure augmentation, didn't see a fistula. We brought her back and raised her pressure to 23 centimeters of CSF, and we see the fistula there. This is with sterile saline using a digital manometer to incrementally measure that pressure. But what I want you to pay attention to more than the fistula is look at the nerve root and meningeal diverticular complex. Look how much more distended it is when we raise that pressure compared to when we don't. This concept was illustrated nicely by Dr. Leutzen and colleagues, an illustrative case here. But I just want you to look at a regular myelogram compared to a lateral decubitus one. And other than the density of the contrast, look at the meningeal diverticulum. It is more distended as a result of gravity. It's no surprise. There's more gravity in that diverticulum. It is more distended. I believe that this is a very important point in finding these fistulas is getting distension of that nerve root complex and penetration of that dye into the nerve root complex itself. This concept of resisted inspiration is very interesting, having a patient take a deep breath in through a straw while we're examining them. And by doing this, we think we're lowering the venous pressure and raising the CSF pressure. Here's a patient that I did without resisted inspiration, and then with resisted inspiration, we see the fistula very nicely. But what I again want you to pay attention to is look at the diverticulum as well. It also is increasing in size during this maneuver too. I think these are 2 sides of the same coin. Pressurization and resisted inspiration is allowing the penetration of dye into that nerve root. So in terms of timing, so here's a patient of an example patient with an immediate run. The first run after injection, we did no resisted inspiration. And we see these sequential axial images demonstrating this internal epidural venous plexus fistula along the dorsolateral epidural space. And then after a couple minutes, we repeated the exam and had them do resisted inspiration, and there's no fistula there at all. So I think that timing can be important. We did a study on this and found that in 1 in 8 patients, if you did not get an early and a delay, you would not have found the fistula. So not the majority, a minority in our experience, but it can be very important. And so here's 3 examples of patients who had this sort of fistula that came and went early. It was only seen on the early image, not seen on the delayed image. And then here's one with the exact opposite, where it was not seen on the early image, on the delay. Again, we're losing that temporal resolution with this technique, and so getting an extra set of images can be very helpful in that regard. I promised you I'd show you an example of a fistula that we found on the photon counter that we did not see on the sort of energy integrating detector. So here's an example of one. I think it's particularly helpful for these internal epidural venous plexus fistulas. These ones that don't drain out of the external epidural venous plexus can be very, very tough to resolve when they're very tiny. And you can see here that exquisite spatial resolution nicely helps us pick out this tiny little fistula here because we have that better contrast and better spatial resolution. Finally, I think it's very, very important that we are very clear with our patients when we are communicating these findings. Sometimes there's some vein that looks a little bit dense, we're not so sure, and we tell the patient, I think I found something, we might try to treat it, I don't know. We've tried very hard to be as clear as possible with our patients so there's no misunderstandings. We surveyed patients and providers and found that the majority of patients, when they had myelography, they felt that there was some uncertainty expressed in their myelogram at some point in time. And they had findings that were kind of not certain, not definite, but possible in them. And the majority of providers, referring providers that we surveyed as well, also would prefer a structured report that sort of expressed uncertainty in some sort of structured way as well. So we try to do this for our patients when we report the possibility of a fistula or not, because again, this isn't always a clear-cut thing, despite the beautiful images we love to show in lectures. So take-home points. So positioning, technique, and timing, they all depend on the type of leak you suspect. A lot of the work is going into this before the actual exam itself. You have to be real-time monitoring with all of these because these adjunct maneuvers, little tweaks can help you find your leak. And then communication is absolutely key with you and your patient, with you and your technologist, and then also, of course, with your surgeon. Thank you.